Hello, my name is Dr. Dale Corraduta, and I'm a resident physician in the Department of Internal Medicine at Duke University Medical Center. And today I'll be discussing lung cancer in preparation for the United States Medical Licensing Examination, Step 2. All right, let's get started. So the goal here is to give you guys the important, high-yield topics in discussing lung cancer. So the things that we're going to discuss today are going to be risk factors, the alarm signs to suspect lung cancer, the different types of lung cancer, and typically we'll divide them into two main categories. And then from those two main categories, we'll break them down a little bit further. The associated syndromes, which are really, really important because you'll probably expect to get at least one or two questions on associated syndromes of lung cancer in your examination. And just general treatment guidelines. We're not going to go into detail on the therapies, but just general treatment guidelines. So when you think about lung cancer, you always have to think about the risk factors. When we see patients in clinic we suspect to have lung cancer, the first question you always ask is, are you a smoker? How long have you been smoking for? Because tobacco is obviously one of the top risk factors for lung cancer. Radon exposure, uranium exposure, and asbestos are also strong risk factors. These are things that you probably encounter in the work environment or to certain environments. Asbestos is important to know that every time we think about asbestos, you always want to think about mesothelioma. So as students, we're kind of taught that when you hear asbestos, the answer is always mesothelioma. That's not always the case. If you have a patient with mesothelioma, then more than likely you can say, okay, this patient was probably exposed to asbestos. But if you have a patient who was exposed to asbestos, it's also important to note that being exposed to asbestos is more than likely going to cause you to have lung cancer than it's going to cause you to have mesothelioma. So that's really important to note. And then it's also important to know this one has two asterisks by it because bronchial alveolar subtype of adenocarcinoma is not associated with tobacco use. So when you have this young patient, maybe in your 30s, 40s, might be a female, comes in and they have a new case, new diagnosis of lung cancer, they don't necessarily have to have had exposure to tobacco if they have bronchial alveolar subtype of adenocarcinoma. So what are the alarm signs for lung cancer? Three important and simple ones, the first of which will be hemoptysis. Anytime somebody presents coughing up blood, lung cancer should definitely be on your differential. The other major thing you're probably going to think about when somebody presents with hemoptysis, at least with frank hemoptysis, is going to be tuberculosis or other infectious causes. The second alarm sign will be weight loss. And when I say weight loss, we're not talking about 5 pounds over a year. We're talking pretty significant weight loss. So patients might be losing 20, 30 pounds over 6 months or over a year's time. And the third alarm sign will be post-obstructive pneumonia. If a patient comes back repeatedly with a pneumonia, typically that pneumonia will be in the same area. For example, you might have right lower lobe pneumonia, recurrent right lower lobe pneumonia. You want to think about it being a post-obstructive pneumonia secondary to a mass effect causing the patient to have pneumonia occurring in that same site. That is an alarm sign for lung cancer as well. Okay, now we have the types of lung cancer. On one of the first slides I mentioned that typically we separate them into two categories. You typically go small cell and non-small cell lung cancer. Small cell is going to account for only 15% of all types of lung cancer, whereas non-small cell will account for 85%. Now, non-small cell is further broken down into squamous cell, large cell, and adenocarcinoma. And the major reason that we want to break these things up from a therapeutic standpoint at least is because small cell and non-small cell cancers are treated completely different. And that's why it's important to have that initial distinction when you have lung cancer. Say, okay, is it small cell or is it non-small cell? Because that's going to affect the way that we treat these patients, as well as their prognosis. Okay, so let's talk about small cell lung cancer first. On these slides, my objective here is just to give you guys the high points, which more than likely, if you're going to be tested on the subjects, they will test you off of one of these bullet points here. So it's important to know that small cell lung cancer are going to be chemosensitive and radiosensitive. Approximately 80 to 90% of patients who receive chemoradiation for small cell lung cancer will have shrinkage of the tumor. At the same time, even though you're shrinking the tumor, you also have to note that small cell lung cancer is very aggressive and has very poor prognosis. At the time of diagnosis, usually about 70% of patients who already have metastatic disease. And from diagnosis until death, it's probably about 2 to 4 months. So the prognosis is very bad, even though it is chemo sensitive and radiosensitive. The places that you're going to be expecting to see metastasis to are going to be your mediastinal lymph nodes, your liver, bones, adrenal glands, and brain. These cancers are centrally located, meaning for your purpose, when I say centrally located, it's important because it'll be easier to diagnose via bronchoscopy. Bronchoscopy meaning essentially taking a camera and going down the airways through the trachea and into the different bronchi. It'll be easier to get a biopsy from doing that procedure because these cancers are centrally located. They're located closer to the airway. And then maybe one of the more important things on the slide here are the paraneoplastic syndromes. For small cell cancer, you want to be thinking SIADH, ectopic ACTH production, and Eden-Lambert syndrome. Probably one of the ones you get tested on the most will be your SIADH. So remember, it's that syndrome of inappropriate antidiuretic hormone production. So these patients are going to be hyponatremic because they're inappropriately producing antidiuretic hormone. Therefore, they're unable to dilute their urine and you're holding on to too much fluid. And then probably the other important one here would be the Eden-Lambert syndrome. And just remember, the Eden-Lambert syndrome is a neuromuscular disease. Okay, so non-small cell lung cancer characteristics. For local non-small cell lung cancer, surgical excision is the treatment of choice. This is important to make the distinction between small cell lung cancer versus non-small cell lung cancer. For non-small cell cancer, which is what we're talking about here on this slide, local disease surgical excision is a treatment of choice, and that is because it's not very responsive to chemotherapy at all. Contrasting that again to small cell, which is very responsive to chemotherapy and radiotherapy. Types of non-small cell lung cancer are going to be your adenocarcinoma, your squamous, and your large cell. For adenocarcinoma, this is the most common type of lung cancer. It's more common in women, and these are peripherally located. The importance of that being because you're peripherally located, you don't typically diagnose them the same way that you would diagnose a small cell, which is centrally located. And if you look down to the next line, the squamous cell cancers as well, those are also centrally located, so those you can diagnose via bronchoscopy as well. But for your adenocarcinomas, you'll be hard pressed to try to diagnose it via bronchoscopy because these are peripherally located. So typically for peripherally located cancers, you'll have better luck doing a VATS procedure, which is video-assisted thoracoscopy. The bronchoalveolar subtype is not associated with smoking. Remember, we said that in one of the beginning slides. So when you have a case where a younger patient presents to you, no smoking history, and they have cancer, they ask you what type of cancer it is. You want to say bronchoalveolar subtype of adenocarcinoma. Okay, on to the next type, which is squamous. For squamous, you want to remember the 3 C's. The squamous cell non-small cell lung cancers are centrally located, and that's important. Why? Exactly, because since you're centrally located, we can do bronchoscopy to make the diagnosis. They typically have cavitary. They can have cavitary lesions, which you'll find on imaging, and they can cause hypercalcemia. And the reason they cause hypercalcemia is because they produce this PTH-like hormone. PTH standing for parathyroid hormone-like hormone. And the way that I remember that they produce this PTH-like hormone is in the word squamous. I look at the Q and I turn the Q backwards, so it turns into a P, and that P reminds me of PTH. So that's how I remember that the squamous are the ones that cause the hypercalcemia. And then the third type will be large cell, which, to be honest, you probably won't get tested too much on, so we won't spend too much time on that. All right, it's also important to remember that with these different lung cancers, you do have tumor burden syndromes. And when I say tumor burden, I mean just the physical nature of the mass itself causing some sort of morbidity with the actual cancer. The first one we have here on the slide is SVC syndrome, or superior vena cava syndrome. And this is the syndrome where the mass is actually obstructing the superior vena cava, and that will cause some facial swelling because you essentially have a backup of blood in the head. You can get headaches from the increased pressure, and that can actually cause you to have syncope and pass out as well. So if a patient comes to you and they have lung cancer and they have this facial swelling, sometimes they'll describe head throbbing, or the head will be actually physically bounding. You can see it in the examination room where the head is kind of throbbing, or they have a headache, or they've been passing out. You want to think superior vena cava syndrome. The second syndrome here, or thing we have here, is Pancoast tumor. And Pancoast tumor is typically a lung cancer tumor they'll be in a certain location and typically in your shoulder area, and it can affect your brachial plexus, and this will typically cause some shoulder pain. It can cause this brachial plexopathy, but probably the most important thing you'll see on the test will be the Horner syndrome. Remember, Horner syndrome is what three things? Exactly, it's going to be your meiosis, which means you'll have very tiny pupils. Ptosis, which means essentially the drooping of the eyelid. And anhidrosis, and these are ipsilateral. And anhidrosis means unable to sweat. So remember, you have ipsilateral, meiosis, ptosis, and anhidrosis. And those three things characterize Horner syndrome. So when you see somebody present with that on the test, you want to be thinking, okay, they've got a Pancoast tumor, more than likely secondary to a lung cancer. And then the last tumor burden syndrome will be your Trousseau syndrome, which essentially is just venous thrombosis. You're at increased risk to form VTEs, or venous thromboembolisms. So staging for non-small cell lung cancer is done by the TNM system. The T stands for tumor, and that's graded on the size and invasiveness of the tumor. N stands for nodes, and that's graded on the degree of regional lymph node involvement, and M stands for metastasis, and that's graded on the degree of metastatic disease. There are a lot of different stages for non-small cell lung cancer, which makes it difficult to memorize, and I don't think that'll be something you have to do for your test. What I would remember, though, is in order to get stage 4 cancer, you can have any T, any N, but you have to have M1A or M1B. M1A means that you have a malignant pleural effusion, or malignant pericardial effusion, or pleural nodules, or contralateral nodules in the other hemithorax. Stage M1B just means you have evidence of metastatic disease. For example, if somebody presents with a pulmonary nodule, which is biopsied and it demonstrates to be lung cancer, and their CAT scan or MRI demonstrates that they have metastatic lesions in your brain, by definition, they're stage 4 already. Staging for small cell lung cancer is much simpler than it is for non-small cell lung cancer. There is a TNM system for small cell lung cancer as well, but the thing that's used the majority of time is the Veteran Affairs Lung Cancer Study Group. Some people call it the VALS-G. There's only 2 categories in this system. Category 1 is limited disease, and that just means that the disease is limited to the ipsilateral hemithorax, so there's no signs of nodes or metastasis outside of that single hemithorax. And then category 2 is extensive disease, which just means that there's metastatic disease beyond the ipsilateral hemithorax. And those are the only 2 things you need to memorize for staging of small cell lung cancer. So it's not quite as extensive as non-small cell lung cancer. So in summary, 3 bullet points to remember from this presentation. Number 1, lung cancer is divided into small cell and non-small cell, primarily because of the aggressiveness of therapy. It's really important, again, when you get that test question, after you've determined that the patient has either small cell lung cancer or non-small cell lung cancer, you have to note that there are differences in the ways that we treat these types of cancers. Number 2, paraneoplastic syndromes can cause significant morbidity in lung cancer patients. If nothing else from this presentation, I would say make sure you know these paraneoplastic syndromes, because these are the things that, if I had to put a nickel on it, I would bet that these are the things that will be tested on. Make sure you know these paraneoplastic syndromes. And number 3, tobacco is the number 1 risk factor in lung cancer patients, with the exception of the bronchoalveolar subtype. So again, that bronchoalveolar subtype is not always going to be associated with tobacco. So if you see a patient with lung cancer, no smoking history, your answer should be bronchoalveolar subtype of adenocarcinoma. Alright folks, I hope that this has been helpful for you, and I hope that you've had most of your questions answered. This should serve as a very good review for you. Good luck with it.